Good morning to all of you. A warm welcome to our CPD webinar organized by GMOA and Society for Health Research and Innovation. Today, we are going to cover an interesting and practical topic in surgery, and the topic is assessment of an acute abdomen in ward setup. Kindly mute your microphone and turn off the camera during the presentation and use the chat box to clear your doubts at the end of the session. Now, it's my pleasure to introduce today's speaker, Dr. Jagath Mallawa, Consultant General Surgeon, currently attached to the Base Hospital, Dambadeniya. Thank you for joining us here today, and the floor is yours.
Thank you. First of all, I would thank the organizing committee of this academy for inviting me to give you a talk about a surgical topic. So I thought it's better to select a common topic which we commonly encounter in our wards for you to have some sort of understanding about the patients who are coming with abdominal pain. So in surgical wards, we will see a lot of patients. Out of them, so abdominal pain with acute abdomen gives us an alarming feeling about what's happening inside and what are we going to do and what is the best management of this patient, how are we going to come to a diagnosis, kind of things. So I thought it's because of that, I thought it's better to talk this topic, giving you some information to think when you encounter this kind of patient in your ward. So first of all, the objectives of this talk is to give you an understanding about how a patient with an acute abdomen might present to you, and to describe the process of evaluation of this kind of patients, considering the available facilities at your unit. Then the next step is to come to a probable diagnosis or definitive diagnosis, which will help us to manage this kind of patients within the available limits of your hospital. And when thinking about these patients, it's better to have a team approach, getting help from the other departments for you to have an overall understanding and to plot a good management plan, this kind of patients. So basically, in developed world, these abdominal pains will come to emergency department. But in our country, we know that our infrastructure has not developed to that extent, and most of these patients will end up in surgical unit, or sometimes they will have a very short stay in emergency department and come to your unit, or sometimes straight away they will come admitted. They will admit to your unit from OPD. So when we talk about the acute abdomen, there are numerous definitions. So out of that, I thought I selected this definition for me to discuss or go on with this topic today. So it says any serious acute intra-abdominal condition attended by pain, tenderness, and muscular rigidity for which emergency surgery must be considered. So we know that in our units, in our surgical units, when we see a patient with abdominal pain, the first thing we are going to think is whether this patient going to have a surgery. So that's why it is very important to have an assessment of this kind of patient by a surgical team. And we are very worried if the patient, if that patient has complained a recent onset pain. And because of these reasons, we have to assess this patient without delay. It means we need to have an immediate assessment to differentiate or distinguish the patients who need acute surgical intervention from the others who can be managed conservatively. So that is called urgent versus non-urgent patients. It's very important to identify the risk group to prevent further progression of the disease and to prevent unwanted serious complications. Sometimes you may know patient can die if we delay the diagnosis or if we delay the to see and prepare this patient to minimize the bad sequelae of this kind of patients. So usually when we're going to see a patient with an acute abdomen, it doesn't mean that all these patients need a surgery. So it depends. So we come to a conclusion after assessing this patient. After coming to a diagnosis that this patient is having underlying pathological process which need a surgery. Otherwise, all this patient, most of this, it doesn't mean that this patient all needs surgery after our assessment. So that is a very important thing to think. So when we are talking about a patient with acute abdomen, so usually start with the epidemiology. It means how common this problem to us when we are practicing medicine. So usually when we talk about an emergency department, it's about 10 to 12% of hospital admissions consist of these kind of patients who are having abdominal pain. Out of that, most of them are having non-specific abdominal pains. It means even though you examine this patient, assess this patient, you won't be able to come to a diagnosis. And with time, these pains will resolve without giving much trouble to the patient, without leaving severe complications or morbidities to the patient. But out of them, about 10 to 15% will need some sort of urgent attention to prevent the further sequelae of the disease. So as you all are practicing medicine in some might be in under surgeon's care, or I mean surgical wards, you will see most of them are colleagues. So this is for your knowledge. And second thing is, when we going to assess a patient who comes with abdominal pain, always think about common causes. So you consider the common causes first rather than rare causes. So how are we going to think that these causes are common and these are rare? It depends on your experience. So if you have practiced surgery or medicine for long period, you know that a lot of patients are coming and they are falling into this category. And some patients are coming with these symptoms and they fall into this category like that. So even though I have categorized these abdominal pains into the etiological groups, so as a clinician, we should consider the common factors first before we are thinking about rare, complicated diseases when we are managing this kind of patients. So pathologically, we can categorize these things into infections. So you may have seen patients with primary or secondary bacterial peritonitis, sometimes pyelonephritis, cystitis kind of things, and some inflammatory process. So they sometimes inflammation can happen together. So sometimes inflammation could be due to infection, or sometimes it may be due to some sort of chemical or some sort of irritational pathology kind of thing. And vascular events like occlusions, ischemia, and sometimes it may be due to obstruction, so commonly uteric colic, biliointestinal colics. So trauma, I have included this topic into this lecture, but trauma usually doesn't consider as a cause of acute abdomen in theory. But in routine practice, we talk about acute abdomen in traumatic patients. It's a sort of a wording. So I thought it's better to add this group for you to have, for you to memorize, or for you to keep it in your mind, that a patient with trauma also can have intra-abdominal events which can present as an abdominal pain, so which warrant urgent or early assessment, which come to a conclusion for proper surgical or non-surgical intervention. And malignancies sometimes, give rise to perforation of viscus. It's common to have colonic malignancies in left side of the colon, sometimes present with perforations. And obstetric problems sometimes. So there is a the sort of a difficult area in surgery where we have to differentiate the pure obstetric or gynecological events from pure surgical emergencies. So obstetric components include rupture of ectopic pregnancy, complicated ovarian cyst, sometimes pelvic inflammatory disease, kind of things. And some medical causes can also mimic as surgical abdomen. Those are sickle cell anemia, where you will have a sort of vaso-occlusive disease in mesenteries. Sometimes they have a distended liver capsule, and sometimes they have splenic infarcts. So these kind of things, when these kind of things happen, patient might present with acute abdomen. So adrenal crisis also, they will have a gross hypotension with mesenteric ischemia, and lead poisoning, they comes with a cramp sort of severe abdominal pain. So when we categorize the causes, so as we did earlier, we can categorize it into pathological categories. But sometimes consider the abdominal topography, which is more useful in clinical setup, to categorize these causes according to the area of origin. So as I have mentioned here, so when patient comes and complain of pain in a particular area, we should have an understanding of the origin of that pathology. So pain. So pain can arise from organs intra-abdominally, sometimes from the wall, and sometimes from the organs or structures outside the abdominal cavity, or from medical causes, or sometimes from neurological causes, sometimes from mental disorders. So it's a broad kind of topic. So we are discussing the assessment of this process. So when a patient complains you a pain in a particular area, so it's better for you to have some sort of understanding where this patient pain comes from. So if you go through this slide, you will see there may be multiple organs that a patient that this patient pain comes from when these organs get involved. So this is the same kind of slide with much elaborative, but the presentation is maybe different according to the age group, because some age, it depends on the common factors. So common diseases which can present in different age groups. So pediatrics, in neonates, you know that necrotizing enterocolitis and midgut volvulus or UTI, constipation kind of things are common. So appendicitis, UTI also common in all age groups. So middle age, so colics, appendicitis and UTI, you have seen that these things are common compared to other things. So you should think these things first rather than other causes. So all the patients, so biliary disease becomes common with some sort of vascular emergencies like mesenteric ischemias and kind of things. And sexually active females, you will have a lot of causes like adnexial pathology, PID, UTI, sometimes ectopic pregnancies. And so these are the things we should consider when we encounter patients in these age categories. So next thing is, when we come across a patient with abdominal pain, So it's better to develop a scoring system. So people have this, I mean, the clinicians have tried to, postulate or create a scoring system for them to have an easy life when a patient comes to your ward with an abdominal pain. But it's very difficult. But here then example, Alvarado score. So one of the scoring systems, which is we utilize this scoring system to come to an idea about whether the patient has got appendicitis or not. So it's a sort of a exercise of a particular unit to have some understanding or develop some sort of scoring system for them to have an idea about the patient's situation. I mean, to come to a diagnosis or conclusion of underlying pathology. So there is no particular properly devised scoring system for us to tell, for us to guide a patient to whether this patient has got a definitive diagnosis. So it's a sort of a practical thing for a unit or team to develop a scoring system depending on the encountered patients to their unit in a particular area. So assessment process. So when patient comes to a unit with an abdominal pain, acute abdomen, usually the assessment starts from history, examination, investigation, and like that. So presentation usually, so we are going to analyze the symptoms of these patients. So we are worried if the patient is having a sudden onset severe abdominal pain. Some patients comes with chronic pains, so which are there for a couple of days or weeks and gradually progressive and warrant them to come to hospital to seek medical care. So onset of symptoms also very important for us to come to a, it's help us guide to a diagnosis. Like if the patient comes with abdominal pain, which has started in minutes. So we know that it could be due to a torsion or vascular event, could be due to torsion or in testicular torsion, ovarian cyst torsion, or rupture of aortic aneurysm. So in that case, other clinical symptoms and scenarios are there. But if we consider the pain alone, so acute onset pains in minutes will guide us to some sort of diagnosis. So you may see some patients comes with the pain for hours. So it could be due to some sort of small bowel obstruction, or could be due to some biliary problems, or sometimes appendicitis, which will progress over hours. But some patients may have pain for days, like in malignant obstructions and inflammatory bowel disease kind of things. They have sort of a prolonged course. So analyzing the duration of pain is important, and which will guide us to have some sort of understanding about the underlying pathology. And the underlying autonomic symptoms, for example, nausea, vomiting, which could be due to the stimulation of autonomics or could be due to severe pain. And depending on the patient's general appearance, whether the patient is ill-looking and whether the patient is fairly all right and he's mobile, or whether the patient is lying still in the bed, or patient is jumping from bed and he's moving and is screaming. So, and whether the patient is having fever or not. So these things are important for us to have an understanding about the patient. We know that if the patient is screaming with pain and moving and he's cannot stand still, it means pathology arising from intra-abdominal organs, unlikely to have a peritonitis. There's a less chance of having peritonitis. If the patient is having abdominal pain And if the movements gives him a severe pain, it means the patient is developing peritonitis due to some sort of intra-abdominal pathology. So peritonitis means it's an inflammation of the peritoneum. So it could be localized, we call it peritonism, and it can be generalized, so we call it peritonitis. So as I mentioned earlier, so there are some important points for us to consider when we are taking the history. So events, what kind of events that patient had before he developed this kind of abdominal pain. Sometimes, patients can develop acute severe abdominal pain in lactic acidosis when they have a strenuous exercise or kind of thing. And past events, that we have seen patients who are coming with pancreatitis have a similar kind of events in the past, and renal stones or ureteric stones, they will have a similar kind of events in the past. The patient may have some have some reports of previous investigation with evidence of stones. And drugs, so we know that patients who have taken NSAIDs for longer period can have acute severe gastritis. Sometimes they can have perforated gastric ulcers coming with severe pain, progressive peritonitis, and hypovolemic shock kind of things. And food habits, that patients who own alcohol can develop pancreatitis, and sometimes alcohol-induced gastritis kind of things. So medical history is important for us to have an understanding about whether this is a presentation of previous disease, acute presentation of already existing disease, or whether the patient has got other medical problems like DK and sickle cell disease kind of thing. So location of pain, as I mentioned earlier is very important for us to have some understanding about the pathological process. So location could be due to localized disease or sometimes due to referred pain. So physical examination, again, a part of physical examination, again, part of the assessment process, give you an understanding about the current state of the patient, whether the patient is bleeding, whether the patient is pyrectic, or whether the patient is in shock, and whether the patient in sepsis, or how about his mentation, whether he can understand what we are dealing with, and to have an understanding about whether it is a localized pain or it's a generalized pain. And percussion note, sometimes we may percuss to see whether the patient has got peritonism. But rebound tenderness is not advocated because which can give rise to severe pain in this kind of patients. So it won't add much evidence to your diagnosis, rather than you are giving much more pain to the patient. And bowel sounds, auscultating bowel sounds, also important because absent bowel sound means whether the patient is in ileus or whether the patient has got peritonitis. So not you can have some understanding about these things. So it's better to remember to examine the genitalia and hernias. Sometimes we will see some pathologies in genital organs like testicles. Torsion can present, but patient might complain abdominal pain, so we may miss it unless we examine scrotum. And hernias, examining hernias are also very important because patients' cause for pain might be a strangulated hernia. And finally, when we are examining the abdomen, digital rectal examination is very important. So you will see some clues which will guide for your diagnosis. Those are blood in finger, masses, sometimes fecal infection, constipation, gives a pain which mimic acute abdomen. So when you are examining the patient, so you will see some signs which are classically described in literature. So if these signs are present, it may guide you to a particular diagnosis. So Carnot sign, so sometimes you may have elicited it. So when patients, the cause of pain is in the abdominal wall or particular area, you can ask the patient to raise his head above the pillow to tense the abdominal wall and palpate whether patient is getting a pain or not. So when tensing the abdominal wall means you are examining the abdominal wall, not the intra-abdominal organs. So sometimes you will see when you are touching or pressing a particular point in the abdominal wall, patient tells you that he's having a severe pain. So Murphy's sign, so designed for cholecystitis. So you will see when you press below the right costal margin, when the patient has got inflamed gallbladder, he will stop breathing in inspiration. So psoas sign, rousing sign. So psoas sign, when you stretch the psoas muscle in patients with appendicitis, they will develop a severe pain. Rousing sign means when you press the left side of the abdomen, the patient will develop the pain in right side of the abdomen. So Gray Turner sign, Cullen sign, and Fox signs. These are for well described in patients with hemorrhagic pancreatitis due to leakage of hemorrhagic exudate in pancreatitis. So these are very important for you to have a clue about the underlying pathology. So, but even though we describe these kind of symptoms and physical findings, sometimes atypical presentations can be there in some age groups. So older patients, you know that their autonomics are not working properly, so they will have less autonomic symptoms. And they are mentally, so probably they are having dementia and they can't remember most of the things. So it's challenging for you to have a proper history. And sometimes their hearing and vision and sort of perception is impaired. So you may not be able to elicit some physical signs. So it's a challenging when you to come to a diagnosis when you examine all the patients. And children also the same. They may or may not be cooperative, and they don't know how to explain their symptoms. They don't know how to react for their physical findings. So it's also a challenge, and you may have to have enormous experience, and you have to utilize certain specific investigations to come to a diagnosis when we're examining this patient. Immunocompromised, you know that immune response is minimal. Sometimes they may not have fever, autonomic symptoms, and they will not give you a proper picture of the underlying pathology due to his immune state. And last trimester of pregnancy, you know that's a physiological phenomenon to have a sort of a large uterus. So because of the presence of large uterus, most of the intra-abdominal mobile structures are displaced. So even though you topographically examine the patient's abdomen, the area of pain, if we focused into an area of pain, it's very difficult for us to understand the underlying pathology because of this displacement of mobile structures within the abdomen. So we need to utilize specific investigative tools to come to a conclusion, to come to a understanding about the underlying pathology in these groups of patients. So when you talk about the pathophysiology of this pain, you know that there are 3 types of pains. Those are visceral pains, these are somatic pains, and preferred pains. So visceral pains mean, due to it's from autonomic nerve fibers. Usually those are sensitive to stretching, chemical stimuli, inflammation kind of things. So those are sort of poorly localized, dull, deep pains, usually in the midline. And when the disease progresses, the somatic nerves can get involved. So classical example is appendicitis. So initially patient have a central generalized kind of pain, later on come to a McBurn's point in right lower abdomen due to the involvement of parietal, the somatic nerves. So those are sharp and well localized. Apart from that, so usually the involvement process depends on the embryological development. Foregut referred to epigastrium, midgut, periumbilical, and hindgut, suprapubic. So these pains can refer to these areas. Why? So the pathophysiology of this process is the visceral nerves and the somatic nerves, they utilize the same spinal segment. The classic example is C2, C3, C4 fibers innervate the diaphragm as well as the right shoulder. If someone is having a diaphragmatic irritation, they complain pain in right shoulder. That's why some patients who are after involvement of the liver and gallbladder, they will have pain in shoulder area. So sometimes you will see a typical presentation. So that can vary, but usually most of the times those are described as typical presentations. So appendicitis, as I mentioned earlier, initially generalized, then right lower quadrant. So cholecystitis due to referred pain. So patient have a right uppercondylar tenderness, and pain can radiate to right scapular region due to this referred pain mechanism. And diaphragmatic irritation, as I mentioned earlier, to the right shoulder area. So biliary tract, right shoulder. So small bowel, back pain, colics, so of short interval. So if we analyze the symptomatology clearly and precisely, these explanations will help you to come to a particular diagnosis without delay. But there's an important point which is well described in literature and medicine. So leaking aortic abdominal aortic aneurysm can mimic uteric colic. So sometimes that it's a well-known factor. So always when you're examining and think of uteric colic, think about the other aspect as well. So evaluation process consists of history and examination, and then we come to laboratory findings. So I will give you an example which has happened recently in my unit. And a young man came to our hospital with epigastric pain, and emergency department was so busy at that time. So patient gave a history of some sort of alcohol intake, and patient was given a shot of ranitidine, so antacid, and patient was transferred to our unit. So because just after the injection, patient has developed some sort of pain relief for a short period of time, then transferred to the unit. But the initial assessment showed that patient's pathology is not resolved and patient's pain is not resolved, it's continuing. So we did the ECG, it showed a huge inferior infarct. So that's why in patients who comes with the epigastric pain, it's better to have an ECG to exclude extra-abdominal causes of acute abdominal pain. Sometimes you may have to take a progressive ECGs with particular intervals to see whether when you going to find the cause for the patient's abdominal pain. Then full blood count is important for you to have some understanding about the patient's hemoglobin level, whether to see if patient's white cells are high or not. In infections and inflammation, sometimes you will see a left shift is there with high white cells and neutrophil count. And packed cell volume to see whether the patient is dehydrated or whether the patient is bleeding or not. And platelet count is also important when a patient needs a surgical intervention. So platelet count is important for you to have an proper planning about this patient's management. A urinary analysis, when we think of a UTI or stones kind of things. So in you will see RBC and cast sometimes in patients with stones, and nitrates are there when the patient has got infection. So if we have the facilities to have a blood gas, so it gives some more information about the patient physiology. So lactosis in sort of ischemic events, and pH also important to see the patient's behavior in next few hours, means 2 hours. And bicarbonate and base X is also given about idea about the patient's physiology, and which will help you to plan the next sequence of the management. And lipase, amylase, these are routine tests if you suspect pancreatitis sometimes. So lipase is more specific, but if you can do both together, it gives a good understanding about the state of the patients. So we know that amylase, if it goes 3 times than the normal value, we can think of some event, the inflammatory process happening in pancreas. And sometimes you will have high lipases but low amylases, then you have to think of some other intra-abdominal inflammatory process apart from pancreas, so kind of thing. So pregnancy test is also important in sexually active females who are in reproductive age. So you can have urinary test or blood assessment, so to find whether the patient has got abdominal pain related to obstetric or gynecological process. So sometimes test to find some socially transmitted diseases. So you can, because some patients comes with PID, so due to some the infection of these certain particular organisms. Second, the set of investigations is imaging. So imaging is useful when we are uncertain about the situation. So if we are certain, then we can plan the management properly. So if we are uncertain, or when we want to confirm the diagnosis which we had in our mind, or to differentiate the causes from surgical versus non-surgical, so imaging is important. So basic imaging we have is radiography, so X-rays, ultrasound scan, and in certain centers, CT and MRI. So imaging of the abdomen. So there are some values of certain imaging modality. Depending on the pathological process, so value change. So for example, right upper quadrant. So basically the biliary pathologies are the ultrasonography is more useful. So you will find the thickened gallbladder, and you will find the changes in the liver and fluid collections in the hepatorenal pouch. And you will see gallstones, and you will see biliary duct dilatations, kind of things. And air in the biliary tree, sometimes in high-end machines with the experienced sonographer. So when there are bowel, when in areas where the bowel is there, it's better to do a CT scan. For example, left upper quadrant and left lower quadrant. So depending on the pathological process, we can add contrast, either IV or oral contrast, for you to have a proper assessment of the underlying pathology. So suprapubic region, we know it's bladder and uterus kind of thing, the organs are there. So ultrasonography is helpful for you to have a reasonable understanding about the patient. So basic imaging like X-rays. So we know that we can take erect chest. So you will see problems arising within the abdomen, and sometimes you will see lower zone pneumonias, which can give rise to abdominal pain. So free air you will see most of the times the free air can be easily seen in right side. Left side you will see a gastric bubble, air bubble. So you should not misunderstand the gastric air bubble with free air under the diaphragm. And abdominal X-rays will give you the fluid levels. Sometimes you will see volvulus, and you will see a pneumatosis in a gut wall, where there is a can be a pathological process or could be due to a non-pathological process. And you will see stones, calcifications when you take a plain X-ray. And then ultrasound scan is useful. You can diagnose a lot of things in ultrasound scan nowadays. So experienced sonographer will give you some idea about the appendix and pancreatitis as well. So if you have the facility to get the ultrasound abdomen, you can utilize that modality to come to a diagnosis easily. You know that patients who are coming with the abdomen, sometimes you may have to have a serial assessment of this patient when the patient is in your ward. Just by assessing the patient once at his presentation will not give you any clue. Then time assessment, history taking, examination, auscultation, assessment will guide you to come to a diagnosis which is very useful to the patient. Then CT abdomen is more useful because that can gives you very important clues to come to a diagnosis, and it will easily detect free air, free fluid, and or bleeding. Sometimes you will see fat stranding in areas of inflammation. You will see neoplasms with perforation, with spread as well. And you will see ischemia in contrast and angiographic studies. And you will see sometimes internal hernias. So I have come across few patients who came with one or two patients who came with internal hernias and mesenteric torsions. So in bowel obstruction, you will see a site of obstruction we call transition point. You can see easily in CT scan. And in injuries, you can see the area of injury and you can assess the severity of injury as well. So basically, it makes the diagnosis easier, makes the surgeon's life easier. So usual common, these are for depending on the history. We can, some sort of protocols can be developed to have an understanding about the underlying pathology. So if the patient gives urinary symptoms, or the patient's symptoms related to colics, or the patient's symptoms related to lungs, then you can proceed on those lines with physical examination and investigations to come to a particular diagnosis. So, and depending on the area of pain and the patient, the history that patient going to give you, you can develop this kind of flow charts, which will make your life easier to come to some sort of understanding and to plan the management of this kind of patients. So these are basic flow charts for you to have an understanding in your ward setup. So this is another slide you will see a patients who have in lower quadrant abdominal pains, and this consists of history, assessment, and which includes imaging techniques as well. So females and patients who are old and frail, so you can utilize this kind of flow charts to have some sort of understanding. So finally, so this patient, I am not going to give you a specific management of particular pathological processes like appendicitis, pancreatitis, cholecystitis, mesenteric ischemia, or etc. So though when you come to a diagnosis, you can plan a particular management according to the underlying disease process. So this is a general sort of management plan for someone, for a patient who comes with acute abdomen. Sometimes you will see the patient is hypotensive and so tachycardic, tachypneic, hypotensive, which says, which gives you an understanding whether the patient has, whether the patient has sepsis or patient has got blood loss or a patient hypolimic. So fluid resuscitation with crystalloids is very important with the white bore cannula. So meantime, same time you can draw blood for relevant investigations. Until you come to a particular diagnosis, you can keep the patients in oral, and you can give pain relief. So trials show that giving opioid doesn't mask the underlying symptoms of pathology. So you can keep the patient pain-free by giving opioids. So if you suspect an inflammatory or infective process, you can give some broad spectrum antibiotics to cover anaerobics and the considering group of microbes as well. So you can give some antiemetics, not in bowel obstruction, and you can consider prophylaxis for venous thrombosis. So for your management purpose, you can insert a catheter, urinary catheter, and NG tube to decompress the proximal gut. And most important thing is to keep the patient under continuous monitoring. So you can connect this patient to a monitor. You can keep this patient in your acute bay. And you can have frequent looks at this patient's parameters. Then you will see the progression of the disease, and you will have an understanding whether the patient is like a progressive disease or whether the patient is going to resolve with his symptoms. So those are very important. So after considering all these patients, when you come to a conclusion that patient is in surgical abdomen, if the patient is stable, you can think of imaging. So you can get time to have a proper imaging to have a clear understanding and to plan your management properly. But if the patient is unstable, so don't waste time for imaging, and you can offer the definitive surgical care for this patient, which will stabilize the patient and which will, that delay, or we can stop the progression of the disease, giving morbid severe complications. So what will happen if we do not diagnose this patient's situation? So patient will develop complications. Some patients will, that resolve spontaneously if the underlying pathology is not severe. But if the underlying pathology is, severe and drastic, and if we miss it, patient can develop complications. So they can give to progressive sepsis, and sometimes bowel necrosis and gangrene, sometimes fistula formation, and finally you will lose the patient. So sometimes now it's a current trend. You have seen that surgeons are using laparoscopy in patients with acute abdomen. Yes, there is a place in current days when there is facilities and expertise are available. But there are some relative contraindications where if you suspect a perforated cancer or gross fecal soiling, or if the patient is, if the abdominal organs are so distended, and you won't have much space within the peritoneal cavity intra-abdominally for you to handle the instruments, and when the patient is hemodynamically unstable. So these are limitations for laparoscopic involvement. So summary, you will see the patients present some sort of with classical symptoms where it's very easy for you to come to an understanding or diagnosis to plan further management. But sometimes they won't have obvious symptoms. They will come with different ways or atypical ways. So if you are not sure about the patient's situation, it's better to do repeated examinations and assessment. So with the progression of the disease within limits, then it will help you to come to a diagnosis or understanding about the situation of the patient. So appropriate testing is important to finalize your diagnosis, to assess the patient physiological state, which will help you to plan the management of this patient. So resuscitative process should go hand in hand to minimize morbidity of these kind of patients. So close monitoring is important in the ward. So keeping this patient in your acute bay and connecting to a monitor and allocating a particular nurse if possible, nursing office if possible, or having a frequent look at this patient to see the progression or the situation, the state of this patient is very important. So as we know, so all patients with acute abdomen should be seen by a surgeon, because surgical team has the more experience on attending and sorting out acute abdominal pains rather than the other medical teams. So other most important things to sharing the information we gather with the patient if he is in a state where he can understand what we talk, or with the guardian to plan further management. So we may have to take the consent and we have to update them about the process. And sometimes we are not in a position to cure this patient situation, and might go, sometimes we may lose the patient. In all these situations, it's better to that give information to about the patient's situation to make their mind or patient prepared for the further events of this disease process. So basically, even though you attended these patients early and even though you plan your management properly, the final prognosis depends on the underlying cause and the patient's comorbidities. So those are the important things that we should remember when we are assessing a patient with acute abdominal pain or an acute abdomen. Okay, thank you very much.
Thank you very much, sir, for that very informative presentation, and that was a clear-cut approach also. And it's time to enlighten few queries from the participants. If you have any questions, please write in the chat box. So we have received one question from a participant. Could you tell about NG decompression?
Yeah, so NG decompression means that that it depends on the underlying pathology, and which is helpful in patients who are sick. That when patient is having a sepsis in the abdomen, the patient might develop sluggish bowel movements and peristalsis is decreased. And sometimes we may have to prepare this patient for general anesthesia to have early intervention. So if you put a nasogastric tube and drain the proximal gut, so it is very helpful for him to recover the bowel early compared to non-decompressed bowel. and which is useful for anesthetist to give general anesthesia if the patient has got a decompressed bowel. You know that sometimes uh, keeping the bowel rest for short period depending on underlying pathology is helpful uh, for his early recovery. In patients with bowel obstruction, so decompression of the bowel is important and to prevent the early perforation, and sometimes in adhesive bowel obstruction. So compression of the stomach will resolve the problem once the once this drainage has been done. So there are some advantages depending on the underlying pathology. So sometimes it will helpful as a part of the management process, or sometimes it's part of it's helpful in the managing these kind of patients in acute state.
Thank you very much, sir. One more query we have got from the participant. What is the role of endoscopy in acute abdomen?
Yes, so we can do endoscopies in acute abdomen if you suspect a particular pathology. You know that most of the times for us to do endoscopy in this kind of patient should be stable enough for us to, take this patient to endoscopy soon. So you may have seen patients who are coming profuse upper GI bleed, could be due to an ulcer, could be due to ruptured varices. You can do endoscopic procedures, but it's very difficult in acute setting. So it demands uh, expert knowledge and skill for someone to do an endoscopy in acute setting of this kind of patients. But sometimes when you're operating patients in large bowel, so on-table colonoscopy has been performed to localize the disease in particular situations. So we have to, that select the proper patient to, utilize these kind of investigative tools to get the maximum benefit when we are planning the proper management of these patients.
Thank you very much, sir. That was a great explanation. And one more query, sir. What are the common mistakes have you noticed while attending the patients with acute abdomen, which are made by medical officers or intern medical officers?
Yes. So as I mentioned earlier, common mistakes that we see when we managing this kind of patients are sometimes we are going to examine this patient and take a history. When we are going to assess these patients, we are going to take the history, examination, and we order investigations, and we wait until investigation comes. Sometimes, depending on the workload, you may forget about this patient. So time interval is most important for these kind of patients. If you are going to attend these patients later, then outcome will be more dangerous. So if you have this kind of patient, it's better to do frequent look at this patient and to see whether patient investigations has been received early rather than late, and whether you are going to that plan this patient's management early, for whether you have got your seniors help as a team involvement. So so taking history, examination, and planning investigations, all we usually do in our wards. But most important thing is to keep a tab on these kind of patients, to see whether the patient is stable or whether the patient is losing from our grip. So if you have a close look at this patient, and if you see that patient is deteriorating, then you have to take the help from proper time rather than it's very late. So that is the most important thing that we should tell you. And if you go to a web, or if you surf the internet, or if you go and refer a book, you will find the steps of managing this kind of patients. But most important thing is to keep a continuous look at this patient and to find whether the patient is deteriorating or improving with time. If the patient is improving, you can have a rest. But if the patient is deteriorating, you should have a more and more involvement with the others to plan a particular proper management to save this patient from the danger we are in.
Thank you, sir. One more query we have got. Would subcut morphine mask the features of acute abdomen?
No,
No,
it
it
has
has
been
been
tried
tried.
with a lot of trials that opioids will not mask the underlying symptomatology. So keeping the patient in pain will stimulate more and more autonomics, and patient become restless, and it will stimulate the stress cascade of patient's physiology. So you can give opioids to keep the patient pain free. So it's not a contraindication to give morphine for these patients with acute abdomen.
Thank you very much, sir. That's all the queries for today. And I would like to thank Dr. Jagath Mallawa for his excellent presentation on behalf of GMOA and Society for Health Research and Innovation. And also we would like to present a token of appreciation on behalf of GMOA and GMOA Sri Knowledge Academy. Thank you very much, sir. That's the end of the webinar today. Thank you all for your participation. And I'm Dr. Sindha signing off today. Thank you.